Hello, my name is Janet Roddy. I'm a rheumatologist practicing in Perth, and I'm also a member of the Australia Scleroderma Interest Group. And as such, I have a special interest in systemic sclerosis, or scleroderma, as it's also called. I'm going to be doing a brief presentation today, which is really an overview of scleroderma. Scleroderma is considered a multi-system heterogeneous disorder, and by this I mean that it's a condition that can affect many systems, and it presents differently in different people. But it almost always involves the skin, and derma in fact means skin, so when you hear the term scleroderma, it means hardening of the skin. In addition, it may involve the lungs, the musculoskeletal system, the gastrointestinal tract, the kidneys, and the heart, and thus it is called systemic sclerosis. We tend to divide systemic sclerosis into diffuse or limited disease, and this really relates to the skin involvement. I'll talk about that in a few minutes. Scleroderma is a rare disease, and estimates suggest that it's anywhere from 9 to 20 cases per million people per year. Although it is most common in women between the ages of 30 and 50, we also see this condition in men and in people outside this age bracket. So almost everybody with scleroderma has Raynaud's phenomena. And Raynaud's phenomena is a condition where you get constriction of the blood vessels, usually involving the fingers and toes, although it can involve other areas. By definition, there is a color change, and this color change is typically where it goes from white to a dusky blue, and then on rewarming goes to a deep red. And the color change is always very clearly demarcated. It's very important to recognize that most people who have Raynaud's do not have scleroderma. And in fact, if you took 100 young women, 16 of them would have Raynaud's phenomena, but a much smaller percentage would actually have scleroderma. The triggers of Raynaud's most frequently is cold, but other triggers such as stress, vibration, such as certain tools, and some drugs can precipitate Raynaud's. We divide Raynaud's into secondary and primary Raynaud's. And primary Raynaud's is when there is no other underlying condition. Secondary Raynaud's is the kind of Raynaud's that you get with scleroderma or systemic sclerosis. To determine whether Raynaud's is primary or secondary, we rely on history, the presence of certain anti-nuclear antibodies, and your doctor will also possibly look at your nail fold capillaries under a microscope to see if there are the typical changes that we see in Raynaud's associated with scleroderma. In patients with scleroderma and Raynaud's, they can occasionally get complications, including digital ulcers, which can become secondarily infected. This is a picture of somebody who has the digital ulcers, and you can see in the top slide a small punched out healing ulcer of the thumb. And then in the lower slide, you can see pictures of ulcers that have healed and have left small scars. Now, this is quite a confronting slide, and certainly this is not the typical digital ulcer, but this is what happens when they do become secondarily infected. And obviously, these ulcers would require fairly urgent treatment with medications. Treatment of Raynaud's, the most important initial thing really is to avoid precipitants. For example, to try to avoid cold. Sometimes that means staying out of the freezer department at Farmer Jack's, and sometimes just making sure that the house is warm and your bedroom is warm. Other things that are very important is to make sure that if you're a smoker that you stop smoking. Also, the clothing that you wear is very important, not just keeping your hands warm, but also making sure that you keep your trunk warm. You can purchase hand warmers, for example, at outdoor adventure stores. You can purchase the little hot shots, or there's something called shin biopacks, which you can purchase online, and they're very handy. You can just keep them with you and use them if the Raynaud's comes on. Nitroglycerin patches can be helpful. Nowadays, we much more frequently use the retrogesic ointment, which is an ointment that's actually sold for hemorrhoids, but it contains nitroglycerin, so it does open up the blood vessels. And that's a topical application. If your Raynaud's is really problematic, and many people with scleroderma do require medications for their Raynaud's, the most common one used are the calcium channel blockers, including things like nifedipine or felodipine. We also use occasionally ACE inhibitors, which are a group of medications which are used to treat blood pressure, and they're also used to treat other manifestations of scleroderma. There are some examples of medications that are used to treat Raynaud's, which in fact do not open up the blood vessels, but work in other ways. And an example of this is a medication called fluoxetine. If the Raynaud's is severe, for example, if you do get digital ulcers, as shown on the previous slides, you may have to take a medication called sildenafil. And especially during the winter time when the ulcers can be more prevalent and more difficult to heal, occasionally patients will come into hospital for an iloprost infusion, sometimes given with antibiotics. And finally, there are some medications that have been shown to reduce the frequency of reoccurrence of these severe digital ulcers. And an example of this is bosentan, which is used in other manifestations of scleroderma, namely pulmonary arterial hypertension. Rarely we require surgery to really get on top of the digital ulcers. The most common surgery for this is where we actually have revascularization of the fingers to improve the blood flow. Other forms of surgery which are occasionally required in the digital ulcers, for example, you may have to do a debridement to clean out the infected area. So the next manifestation I'd like to speak about is the skin involvement. As I mentioned earlier, almost all patients with systemic sclerosis have skin involvement. There is one rare form, however, where there is no skin involvement, and I'll mention that later. The skin involvement starts in the hands, generally in the fingers, and then if it's going to progress, it progresses upwards to involve the upper arms and then the trunk. So the first sign may be very puffy, itchy skin involving the fingers, might make it difficult to wear rings. Sometimes it makes it difficult to pick up small objects because of the puffiness. The skin involvement is how we define the condition into diffuse or limited. And basically, if the skin involvement is above the elbows or above the knees, it's considered to be diffuse, compared to below the knees, below the elbows, and involving the face, where we consider it limited disease. We use a clinical score called the Modified Rodman Skin Score to help us understand how fast or if the skin is progressing. Some of you may have been involved in the study we did looking at ultrasound, which is also have some utility in measuring skin thickness. And again, for some people, the skin is really not too much of a nuisance, but in other individuals, it can become a real problem. And some of the complications include difficulty with mouth opening. So for example, the dentist may have difficulty performing certain procedures. You can get contraction of the fingers if the skin is very tight in the hands, and the hand therapist can help with this. Likewise, you can get some tethering of the skin, which makes it quite thin and prone to not healing wounds well. And some of the rarer complications, such as calcinosis, can occur. Some individuals will have telangiectasia and changes in the pigmentation. And I really can't emphasize enough that the discussion today just brings up some of the possibilities that individuals may experience with their scleroderma, but by no means will everybody experience all these manifestations. So this is a picture of the very early puffy finger phase. So we call this the edematous phase. And in general, we define this divide the skin involvement in scleroderma into 3 phases. So this is the first phase where you may feel itchy, they're puffy, you may have difficulty with making a grip. This is a picture of calcinosis. Now, many people will have just very small amounts of calcinosis and they won't even notice it, but it will be their doctor that picks it up. And this is someone with obviously a more florid calcinosis. And again, as I said, this only occurs in up to 10% of patients with systemic sclerosis. So many of you will have heard of the term CREST, which is really an acronym for a form of limited scleroderma, and it stands for calcinosis, Raynaud's, esophageal dysmotility, which I'll talk about in a minute, sclerodactyly, which is another name of the thickening of the skin on the fingers, and telangiectasia. This next picture is one of quite widespread telangiectasia, and again, most people who have telangiectasia, they'll be much less evident than this. Often they occur on the hands, and many people don't even notice their own telangiectasia. It's not until they're pointed out, but some people do have more troublesome telangiectasia. So the progression of skin in scleroderma can be very distressing, as it often can be quite rapid early in the course of the condition. And it does indicate the development of other organ involvement in some individuals. And that's why we monitor it so closely. In general terms, over the first 3 to 5 years, that is when the skin progresses. And the natural course of the condition is that after this period, the skin will start to regress. So as I said earlier, it generally starts in the fingers and feet and then moves upwards. When it starts improving, it goes the other way. So most people after this period will notice skin softening even without treatment. However, we do now have very good treatment for skin involvement. And again, we start with very simple things like lanolin-based cream. Some people find dermies, which you can buy over the counter, very helpful. Avoid frequent washing to stop the skin from getting too dry. In that early puffy edematous phase, when the skin can be quite itchy, antihistamines can help. We try to avoid steroids in scleroderma, even topical steroids, but sometimes they can be quite useful. Immunosuppressants are used much more frequently now because we've had studies that have shown they really do make a difference. The most commonly used agent for skin involvement is one called mycophenolate, which is also helpful for people who have lung involvement from the scleroderma. Methotrexate has also been shown to be useful in slowing the progression of skin disease, and that's actually quite helpful for some of the arthritis and the musculoskeletal manifestations. Cyclophosphamide, which is a very strong medication and is rarely used just to treat skin, but it has been recognized that it will help slow the progression of skin disease. And finally, there's been some studies looking at something called autologous stem cell transplant, which we only use in the most severe forms of scleroderma, and that does help the skin, but generally we would not recommend this for people who just have skin involvement. The calcinosis is quite difficult to treat. There are several medications which are helpful in some individuals. For example, the calcium channel blockers that I mentioned, things like nifadipine and felodipine, can be helpful. Sometimes we use immunosuppressive agents if the calcinosis is widespread, such as methotrexate or azathioprine. And sometimes antibiotics like minocycline are used, not because this is an infectious complication, but because some small studies have suggested in some individuals it is helpful. However, we certainly don't have the answer for the calcinosis in all individuals, and we are currently involved in some studies looking at some newer agents. Lung and heart involvement is something that is very important to screen for in all patients with scleroderma. Now, many patients will not have symptoms early, or they may just have very minor shortness of breath with exertion. However, we know if we pick up lung or heart involvement in patients with scleroderma, we have very good treatments, and the earlier we get them started, the better the outcome. So I'm just going to touch briefly on both the lung and the heart, but it is a very big topic and it would be impossible to cover it in a short time. The major manifestation of the lung disease in scleroderma is what we call interstitial lung disease, and that's where the lining of the air sacs becomes thick because of inflammatory disease. The most common form is something called NSIP, and some of you who have scleroderma or have family members who have scleroderma may be familiar with this term. The best way to detect this involvement is with pulmonary function tests or a high-resolution CT scan of the chest. It's very important to know that in many cases, the interstitial lung disease will not in fact progress, but it's very important to have a baseline so you can be monitored to make sure if it is progressing that we can pick that up early and initiate therapy. We have many very effective therapies in interstitial lung disease in scleroderma, and some of these include the same agents that we use to treat the skin disease, such as mycophenolate. And as I mentioned, for lung disease, we often use the stronger treatments such as cyclophosphamide. Much as we don't like using steroids if we don't have to, lung disease is an area where we may need to use steroids. Some people are taking azathioprine, and rarely, if the lung disease is progressive, we may consider autologous stem cell transplant. I'm just going to touch briefly on the complication of pulmonary arterial hypertension. Now, this is a very rare complication in systemic sclerosis, occurring in probably 13 to 15% of patients with scleroderma. However, again, if we pick it up early, we have excellent treatments. So because of this, we recommend all patients with systemic sclerosis have an annual echocardiogram. Although to make a definite diagnosis of pulmonary artery hypertension, more invasive tests like a right heart catheter are required. However, again, to emphasize that most patients with scleroderma will not require these investigations, but it is very important to monitor carefully. So the therapy for pulmonary arterial hypertension, it includes things like macitentan, sildenafil. Sometimes we use these agents in combination, and there are other agents that are used. We usually involve the pulmonary arterial hypertension clinic or other respiratory physicians with an expertise in this area. I'm going to talk about kidney disease next. And again, like most of the severe organ manifestations I've mentioned, this only happens in a small percentage of patients with scleroderma. Most frequently, the kidney disease will occur in individuals with the rapidly progressive diffuse skin disease, and usually it occurs in the first 3 to 5 years. It's termed a scleroderma renal crisis. The most important thing I can tell my patients with scleroderma is to monitor their own blood pressure, especially in this early phase, as that is the best way to pick up the development of this form of kidney disease early. Your doctor can tell you the parameters that you would look for when you're monitoring the blood pressure, and they can also discuss with you some of the other symptoms that you could experience. As I've mentioned throughout this talk, in scleroderma, we try to avoid using steroids wherever possible. And the major reason for this is the development of kidney disease is increased in patients who take steroids. Again, if you pick up the kidney disease early, people respond very well to ACE inhibitors, especially if they are started promptly. I'm going to speak now about some of the musculoskeletal manifestations of scleroderma. Early on during the phase where you have the puffy hands, you can get carpal tunnel syndrome, which causes a tingling in the fingers. Joint pain, which we call arthralgia, or even frank arthritis, can occur in scleroderma. When it is the joint pain without the true arthritis, sometimes just Panadol is sufficient. Although anti-inflammatory agents may be helpful, we do try to avoid their use where possible because they frequently will aggravate the reflux symptoms that so many patients with scleroderma experience. Plaquenil can be very helpful for the arthralgia, and sometimes we use methotrexate. It also works in skin, so in those individuals where they have rapidly progressive skin disease and arthritis, it's a very good option. Eliciting the help of a hand therapist can help prevent joint contractions and also give you some tips on how to work around some of the symptoms that individuals experience with the hand involvement. Just a brief word about myositis, because that can be quite difficult to treat. It can cause muscle weakness, and it generally does require immunosuppressive therapy. And also we do have to frequently use steroids. As I mentioned earlier, we do try to avoid steroids, but for some manifestations, including myositis, they're often necessary. Involvement of gastrointestinal tract occurs in almost every scleroderma patient, and any part of the gastrointestinal tract can be involved, although by far the most frequent occurrence is esophageal involvement. And many of you have heard of GORD, or gastroesophageal reflux disease, and that causes heartburn, can cause difficulty swallowing, and if it is not treated promptly, it can result in erosions, which then can cause some bleeding and anemia. And if not treated for a prolonged period, or it's quite severe, it can result in strictures in the lower part of the esophagus, which can cause difficulty swallowing. And rarely you have a Barrett's metaplasia associated with the esophageal involvement. We generally recommend endoscopy in individuals with scleroderma esophageal involvement, because then you can take biopsies if needed, and you can also really have a very good look at the esophagus, although a barium swallow is sometimes used. Most frequently, a test called esophageal manometry, where they can actually measure the motility of the esophagus. Sometimes that is important when we feel that people may be having aspiration into the lungs from the ongoing esophageal dysmotility. But as I said, this is a less frequent investigation. Some of the treatments used in gastrointestinal involvement are really lifestyle measures, and I can't emphasize how important these measures are. Not having meals after 6 p.m., trying to avoid spicy foods, alcohol, and again, avoiding cigarettes. Sometimes just placing a brick under the head of the bed will help gravity work during the night to help drain the esophagus. And so that's a useful technique. Certain medications such as opioids and anticholinergics like Endep can aggravate esophageal involvement. Many of you will be familiar with Nexium, which is a proton pump inhibitor, or a PPI. Most patients with scleroderma will have required a proton pump inhibitor, and often at an increased dose. Other agents that can be helpful are from a group we call the H2 blockers, which include nizatidine, and we often use them in combination. Some patients get some improvement with Gaviscon, especially before bed, and sometimes taking a motility agent like domperidone before meals can be helpful if people have difficulty swallowing. As I mentioned, many people with scleroderma can have involvement of other parts of the gastroesophageal tract, including the stomach, where you can have delayed emptying, and this can result in nausea or vomiting even after meals. Occasionally, when it's severe, it can also result in weight loss, but this is the minority of patients. There is a condition called GAVE, or gastric antral vascular ectasia, which is usually diagnosed with endoscopy, where it has a very characteristic appearance. And this can result in anemia and does require iron replacement, and this often has to be given by infusion. And again, we have an effective form of treatment for this, which is called argon laser coagulation, which is done at the time of endoscopy. So in individuals with scleroderma who have persistent unexplained anemia, it's certainly worth investigating this possibility. Moving down the gastrointestinal tract to the small bowel, there is a condition known as small intestinal bacterial overgrowth, or SIBO. Individuals where their small bowel doesn't move well, they can have an overgrowth of bacteria, which can result in cramping and abdominal pain. Sometimes this is settled just by a change in diet, and we frequently suggest people try something called a FODMAP diet, which is available online. Other manifestations which can involve the small bowel but are rare include pseudo-obstruction or volvulus. The large bowel is often affected in scleroderma, but sometimes it can really not be a terrible problem. For example, people with scleroderma can get diverticuli, and this can result in diverticulitis. Probably a more significant problem for patients when they have large bowel involvement is when it affects the anorectal sphincter, and that can result in stool incontinence. As you can see, the gastrointestinal manifestations would be a talk in of themselves, so I've just tried to briefly cover some of the manifestations of scleroderma. I'd like to summarize my talk by pointing out that systemic sclerosis affects people differently. While some people may have very severe disease, many will have milder disease, and we do have excellent treatments for almost all the manifestations of scleroderma. It is very important that people get an early diagnosis and appropriate treatment, and this has to be initiated early to prevent some of the complications that I've mentioned. Whilst many of the manifestations, if they are going to occur, do so early in the disease, pulmonary arterial hypertension can occur late in the disease. So individuals with scleroderma do require lifelong monitoring, particularly for this complication. To end on a positive note, there are many new therapies available for scleroderma, which have really changed the outlook of this condition. And there are new therapies which are in the research phase. So thank you very much for being part of this webinar, and hopefully we will be able to field some of your questions in the Q&A session, which will be advertised through the Arthritis Society.